Okay, so very good evening.
Bidita,
COVID is giving us a lot of nightmare, but then today this is the opportunity to talk about nightmare and other nightmare associated diseases which we see in adults. My presentation will be under the following components. Now, dreaming. This is the most complicated and the mysterious aspect of sleep. The dreams are visions of grandeur and bliss, but then sometimes they may be scary, stressful, or even threatening. When I have a nightmare, first thing which comes to my mind, am I the only one having it? As an adult, should I not have outgrown of it? Well, to speak of nightmare in a very simple word, they are vividly realistic, disturbing dreams that rattle you awake from a deep sleep, most often in early morning hours. They often set your heart pounding from fear. But then, scientifically speaking, the definition of nightmare and nightmare diseases, disorders or diseases, as said in DSM-5, is repeated occurrence of nightmare, which are extremely dysmorphic and well-remembered dreams that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning, which are not attributable to the physiological effects of a substance, that is drug abuse or medication, and which cannot be adequately explained by coexisting mental and medical disorders. There are various associated symptoms of physical arousal like sweating, shortness of breath, palpitation, and elevated indices of periodic leg movements. There are emotional component also, of which most prevalent is the fear, but there can also be anger, shame, and sadness. It has been seen that people with nightmare disorders have increased risk of suicide, and these emotions can occur during the dreaming episode, on awakening from the disturbing dream, or when they're later recollecting that experience. Other functional areas which may be affected may lead to mood disturbance, sleep resistance, cognitive impairments, and negative impact both on the mental as well as the physical health. Now, often a question is asked, if you remember the first definition which I said, that you are rattled awake. So does the dreamer need to awake? So there's an ongoing debate on it, but then now what has been decided is that though nightmares will often lead to awakening, in DSM-5, the criteria which they have said is waking up is not necessary. So you may not actually waken up from the dream, even then it can be a nightmare. They are classified on the basis of duration into acute when they are less than 1 month, subacute when they are 1 month and less than 6 months, and persistent when it is 6 months or more. Severity wise, they are classified as mild when there is 1 episode per week on average, moderate when there is 1 or more episode per week, but it is not every night, and severe when episodes occur every night. Coming to the epidemiology, the true prevalence is not known. The reason being, there is a lot of underreporting, a lot of misdiagnosis, and the terminology and the criteria which have been used for defining nightmares across various studies, there's a lot of heterogeneity in that also. But then it has been noticed that almost 85% of the adults have nightmare at least once in a year. 2 to 6% have reported weekly nightmares. Coming to the gender distribution, females seem to have a little more in the ratio of 1.5:1 in adolescence and young adulthood. However, in younger children and in 60 years and above, it is equal in both the sexes. Now, what is the time or what is the stage of the sleep when the nightmare comes? As we all know, this is the rapid eye movement sleep, and this is during this REM, which otherwise is our last third of the night or early morning when the nightmares come. It is very uncommon to have it during the NREM sleep because for the simple reason we don't dream at that time. But there's an exception. When there are nightmares associated with post-traumatic stress disorder, you can have nightmares in any of these stages, starting from stage 3 to stage 5. The causes: trauma, history of trauma, a previous trauma can lead to PTSD, post-traumatic stress disorder, acute stress disorder, and a nightmare disorder can be associated with them, or it can be a subthreshold symptom of any of them. Again, nightmares may be associated with psychiatric disorders like depression, anxiety, schizophrenia, or borderline personality disorder. There are certain medications like antihypertensives, the beta blockers mainly, dopamine agonist, antidepressants, antimicrobials like mefloquine, ciprofloxacin, erythromycin, and certain other ones. Withdrawal from medication or substance like alcohol, barbiturates, benzodiazepines, and antidepressants. Antidepressants can cause it, and the withdrawal of it can also again cause it. And of course, there are many which are idiopathic frequent nightmares. The pathophysiology of it is quite complex. This integrative model is the one which is most accepted. To make it simple, the main features are impaired fear extinction and hyperarousal, and these two interact with each other. Now, these two are affected by physical factors like chemosensoric pathways, hypoxia, by trait affect disorders like traumatic experiences, childhood adversities, or susceptibility to negative and positive contexts, and to various cognitive beliefs. Now, when these two interact, it gives rise to a perceived similarity. Now, this may convert into specific dream contexts, which may not actually go into a nightmare disorder, but a simple episodes, or it may go into a nightmare script. And this is actually like a replay. The person keeps getting this nightmare, and this causes distress, and this leads to insomnia or sleep disturbance, and the sleep disturbance itself further precipitates the nightmare. How do you evaluate and diagnose it? We should remember that nightmare disorder diagnosis is completely a clinical diagnosis. So you need to have a very comprehensive clinical evaluation. You need to differentiate it from the mimics, which I will come in the next few slides. An evaluation questionnaire, there are several available to first diagnose nightmare disorders, then to find out what is the effect of these nightmares on other systems. What about polysomnography? Is it required for diagnosis? Well, not. But then it has a great role to exclude other parasomnias and sleep disordered breathing. In DSM-5 diagnostic criteria, which I already mentioned in the second slide, this is the criteria. This definition has already been spoken, but here they have added, it involves efforts to avoid threats to survival, security, or physical integrity. Also, a very important point is, on awakening from the dysphoric dreams, the individual rapidly becomes oriented and alert. The rest has already been dealt with in the previous definition. So now this is the latest which we have about the diagnostic criteria, and this is what is followed for diagnosing a nightmare disorder. The various mimics which are there are REM, sleep behavior disorder, sleep terrors, very commonly mistaken for nightmares, nocturnal panic attack, hypnopompic or hypnagogic hallucinations, bereavement-related dysphoric dreams. In nocturnal seizure, the nightmare may be actually the aura, and sleep-related breathing disorder. So when you are taking a history, you need to diagnose not only a nightmare disorder, you need to exclude all this before you reach a diagnosis. Coming to the management, the most important part of the management is the lifestyle modification and advocating a sleep hygiene. And this is a condition in which a top-down approach is maintained. By top-down approach, the researchers, they mean that you take a comprehensive clinical history, do a physical and a psychological evaluation, reach a broad diagnosis, then narrow down whether the person has a nightmare disorder. If you think it is a nightmare disorder, then go further down and narrow it whether it is associated with a psychiatric illness. So here it is a top-down approach which needs to be done. Now coming to the lifestyle modification and the good sleep hygiene, what all can you tell the patient? One is he should seek out healthy social interaction to promote emotional stability and sense of well-being. During this time, very, very important, we keep saying that avoid the various news, avoid the various WhatsApp, which is giving all negative histories. Do not go much into it. Take a warm shower or empty the bladder just prior to sleep. Exercise regularly, but not within the 4 hours of sleep time. You can have a walk, but not any other exercise. Avoid greasy, fatty food close to bedtime, but then also remember not to skip meals, because if you're hungry, again, that can influence the sleep quality. Avoid alcohol, caffeine, and nicotine close to bedtime. A consistent schedule should be there for your sleep and daytime function. A comfortable environment which is conducive to good sleep. So appropriate bedding, your bedroom should have a soothing color, a soothing temperature, noise levels should be low. Establish a healthy, relaxing bedtime routine, and avoid television, computers, and screens for at least an hour before bedtime. Again, very difficult with the IPL and the other things going on. Usually we are on the bed, we see it, and we go off to sleep. And very, very important, use bed only for sleep. So these simple good sleep hygienes help a lot in taking care of the nightmare disorders. Apart from that, there are few treatment approaches which have been defined. First approach is to find out the subjective meaning of the nightmare. So this again includes all of history taking and getting into the actual meaning of what the nightmare or what effect does it have on the person. The second is to approach the pathologic repetition of the nightmare. It has been seen that the nightmare disorder is actually an overlearned behavior. I repeat, it's an overlearned behavior, and the aim is to unlearn this behavior. And to do this, we have desensitization and exposure therapy, imagery rehearsal therapy, and lucid dreaming. All three are backed with level 1 evidence, a lot of RCT is done on it, and they have a very good role to play. Also, the other approaches which can be taken care of are to approach the maladaptive beliefs about the nightmares. So you need to change the maladaptive beliefs by means of behavior, the experiments, and constructive cognitive restructuring and paradoxical intention. Pharmacological treatment, well, we have many which are there, but then what about the evidence? We have level 1 evidence only for prazosin, and so prazosin is indicated for nightmares disorder otherwise also, and also is the best drug for the PTSD related nightmare. Regarding all the others, we don't have much of evidence. Now we have negative evidence for venlafaxine. It does not work in nightmare disorder, so it should not be used. Regarding clonazepam, though it has been used very, very often, there's very sparse data and studies are still on, so they have not commented. The guidelines which are there have not commented on it. Lack of knowledge is a very important thing which we need to know. The screening and treatment remains rare, even in sleep center. Most of the nightmare sufferers, they do not seek professional help because less than 1/3 believe that they can be treated. 38% report to healthcare provider. Of that, 1/3 to 1/5 of the sufferers who sought professional help received helpful advice. So what is the future? We need to actually get into the etiology of the nightmare disorder by having clearly defined criteria. We need to see the interaction between the psychoneuroimmunology and psychoneuroendocrinology, and interplay between the pathophysiology needs to be studied. We need continued development of nightmare treatments by having robust data by conducting RCTs. Application of nightmare treatments in different subpopulation has to be researched, and very important, integration of nightmare treatments into the healthcare system. The screening should be made efficient and easy so that it fits within a primary care or physician visit, and it educates the healthcare professional to make appropriate referrals. There are various myths, facts which are debatable. Nightmares are reflection of emotions or daily events. Yes. Animals have nightmares. Yes, it is true. Scary movies, if you see before bed, will give you nightmare. Maybe. Dreams control your body when you're sleepwalking. Well, no. Nightmares, they feel that they are long, but actually they are small. We don't know. So many mythology is there behind nightmares. So it has been there since ages and it still remains. So the take-home message is, nightmare disorder is a clinical diagnosis. It is rare, often missed, but treatable. Prompt and proper referral is what is required, and there are many unresearched areas. So during this period of COVID pandemic, where we all are stressed, it is very important that we support and take care of each other. Thank you very much. Stay safe and healthy.